Good morning, everybody. Welcome to Medical Grand Rounds for this Friday, the 23rd of February. Before we begin, I'd like to respectfully acknowledge that we're located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, and many others, whose histories, languages, and cultures continue to enrich our vibrant community. This morning, we're going to hear from Dr. Naheed Rajabali, a member of the Division of Geriatric Medicine. He's an assistant clinical professor and received his training in internal medicine and geriatric medicine at the University of Alberta. He primarily works at the Royal Alexandra Hospital on the acute inpatient wards and consult service. He also takes an active part in the geriatric medicine emergency department consult service. He's a bundle of energy. Our main task with Naheed is to actually get him to be quiet, but actually that's his task today, is not to be quiet. He leads on the new complex perioperative perioperative assessment clinic, and complementing his research and clinical roles, he's actively involved in teaching and medical education. And this morning he's going to educate us. He's going to give us some clarity, we hope, on states of confusion, distinguishing delirium versus dementia versus BPSD, versus primary psychiatric disorders in older adults. And without further ado, I'll hand you over to Naheed. Thank you.
Thanks for that warm welcome. Good morning, everyone. Really not much to disclose, for better or for worse. So, the objectives have been highlighted in the document, but we're going to essentially, look at confusion, the concept of acute brain failure. We're going to distinguish rapidly progressive dementia from BPSD, from primary psychiatric disorders. We're going to look at contributing factors and practical approaches, and we'll get through the cases acknowledging that we have a broad, audience members from students, residents, colleagues, and so on. So what about confusion? Confusion. Well, how about this? The inability to diagnose or delayed diagnosis is bad. There's a lot of statistics out there, but frankly, I don't remember them all. I just remember it's bad. And so confusion about confusion is bad, and clarity about confusion is better. And the source, just trust me on this one. Okay. So it's a vague term. Altered mental status or confusion is a vague term, and it encompasses a host of issues. So there's delirium or encephalopathy, which I kind of think about as acute brain failure, which includes also seizures with impaired awareness and syncope. Of course, BPSD, active or decompensated primary psychiatric states, and rapidly progressive dementia. But first, we use the term elderly and old age. Even amongst geriatricians, there's a debate about that term. In reality, there's no switch at 65. There's no genetic switch. It's really, it's derived in the 1930s, and it was an expedient answer to a social and political pressure for things like pensions and health insurance. And even the physicians and scientists at the time were looking for a biologic sort of age cutoffs, but it would have taken time. What we see in reality is that the aging and chronic disease demographic is truly heterogeneous. And so the World Health Organization has actually removed the term old age from their ICD because they found it to be of limited use, the chronologic age, for diagnosis, prognostication, and treatment, and promoting healthy aging. So I like to use the term intrinsic capacity or physiologic reserves or biologic age or fitness and frailty. These are all sort of synonymous. And essentially, it really is, you can look at it in terms of at the brain level, intrinsic capacity. We're familiar with things at the organ level, with renal failure and so on. I don't know, gut, Adriana, I don't know, do we have, I guess, for specific things like the liver, she stepped out. We have different things, but okay, there. But then we can look at it in terms of systems and then functional levels. So there's intrinsic capacity. How much stress can you withstand? And that's essentially what the term intrinsic capacity or fitness and frailty is. How much reserve or resilience do you have in the face of a stressor? And there are ways of measuring it. So I think I'm sort of going over and over about it, but it is the other equation in medicine that we seldom systematically address. We look at age, but it's not really good. We're all familiar with stressors, disease, and treatment, but this is really an emerging concept in all areas, including with what I'm about to talk about. So let's look at cognition, intrinsic capacity of cognition. The brain helps with function, filters, behaviors disinhibited, well, inhibits and filters behaviors for some people more than others at baseline, but you get the point. And then perceptions of reality also is responsible for. And then there's your physical capacity, your overall strength. And then your spirit, you can't discount that. It's kind of fluffy in medicine to talk about these things, but we see patients with full cognitive and physical capacities, but they're not good in spirit. So back to the topic, altered mental status. Let's talk about acute brain failure or delirium. What is the DSM-5? How does it describe it? It talks about a disturbanceness of consciousness, a change in cognition, which is not dementia, disturbance that develops over a short period of time, which typically isn't dementia, and tends to fluctuate. And there is evidence that the disturbance results from a medical condition, substance intoxication, or withdrawal. So there is a stressor that you can often place your finger on. And to sort of screen and identify, there are many sort of tools you can use, but there is CAM, which is a bit more firmly established. And it addresses the acute onset of the situation. Inattention, I use the term engaging because patients with long-standing dementia will eventually be inattentive to some extent. But that's how I distinguish the two. Are they engaging or not? And then either or disorganized thinking or altered level of consciousness. And it's got a high sensitivity, specificity, and reliability as a tool. And just one thing about fluctuations, it's usually not normal to really bad, to normal to really bad. It's usually bad to very bad. Unless, of course, the inciting factor likes taking a bit of a break. But usually things that cause delirium don't, whether it's an infection or a toxin and so on, right? So if you do find somebody that's normal, not normal, or at their baseline, and especially in the morning and so agitated in the evening, think it may likely be BPSD rather than delirium. That's just a small point there. And we'll learn about why it's important to distinguish the two. So patterns of brain failure, I think about it in terms of hyperactive. I think, agitated psychosis, inappropriate, behavior, hypoactive, lethargic, increased somnolence, and in worst cases, coma. But I also like to think about it in terms of what makes me really worried, right? So is it florid CAM positive? We need to do something about it now. You can't walk away from it. You have to do something now. I don't know, maybe, hypercapnia from COPD, you need to get that BiPAP on now, right? Evolving, so something's brewing, patient's not quite florid, but it's going to head there. That's still worrisome. And resolving, you've dealt with the issue. Now you're going to let it ride. And don't let your guard off completely, but you can breathe a bit. So there's contributing factors, so stressors, anything that disturbs homeostasis. So we're all familiar, and then intrinsic capacity. So we're all familiar with DIMS, so I won't really get into that too much. And then there's intrinsic capacity, so dementia, or at the organ level, do they have COPD, do they have severe CKD, could it be uremic encephalopathy, are they not clearing drugs and whatnot, cirrhosis, same thing, and overall diminished capacity. And the thing I like to remind people is if you have diminished reserves or intrinsic capacity, there's a lower threshold for acute brain failure. So don't generalize, the 70-year-old is coming in, it's probably the UTI. Well, it could be actually something else if they actually have, good, strong reserves at baseline. Okay. So determining cognitive reserves at baseline. So if someone's in acute brain failure, how do you know what their baseline reserves are like? Well, you can't do screening tests because you're not going to trust them. If they're in florid delirium, they're not even going to do the test, let alone even engage with you. And so it's often challenging to rely on patients for history. So there's often collateral history. Majority of the time, this is how we get it. There's usually reliable collateral. There's a previous history somewhere. It may not implicitly say this patient has dementia or not, but when we go through like a bit of the criteria, you can make out that they actually have diminished reserves. You can inference it. I mean, if they have large multiple strokes or quite a bit of atrophy in the brain, et cetera, there's history of, EMSs that have left their home unkempt and so on, or decades of things like alcohol or substance abuse or traumatic brain injury, it increases your probability. And the key thing to remember is any history of cognition-dependent functional decline is not normal in aging. There's never a good age where you all of a sudden need help with finances or booking appointments and so on. It's not normal. So how do you determine baseline reserves? So I just try to determine if they have dementia or not. That's really what I'm trying to do. And there is a National Institute of Aging criteria for all-cause dementia. Here's the reference. And essentially, it just says there's no age cutoff, by the way. It just says from your baseline, do you have a decline? And it's not explained by primary psychiatric disorder. These things don't happen later in life. I shouldn't say they don't, but it's very rare, exceedingly rare, to have all of a sudden bipolar as a new diagnosis. And you can have a subjective history. Some people have insight with their cognition. You can get collateral. You can even do a bedside assessment, and often you're able to tell if the patient's vague, and so on. And then it has to impact their ability to remember new information, visual, spatial, language, and so on. And what I like about this criteria, it acknowledges changes in personality and behavior. Your brain's responsible for being a filter, and perceptions of reality, it's keeping those intact. So if it starts failing, of course, it's going to be a marker of dementia. Okay. So, the important thing to also note is no age cutoffs. It's an all-cause criteria for us, it doesn't involve screening tests, which can potentially be useful, but often people with early or emerging dementia or mild will likely have high scores. So but they're screening tests. Okay. The other thing to remember is severity of dementia. Often we just say dementia and people have different ideas of what it looks like. We need to start getting into giving them severity scores like we do for everything else, right? For heart failure, we have the New York Heart and the EF, for COPD, we have the GOLD and the MRC, because it means something. So for dementia, if you're going to go that far, give it a severity score. There are validated tools, and they kind of work on the premise that the brain unravels from cells that have the least amount of plasticity to the most. So what you learn last in life has the least amount of plasticity, your job, a new instrument that you just recently learned, and you unravel that way. So there are several tools that you can use. There's a few more than these, but these are the easiest ones. I don't often ask domain deficit questions because everybody thinks that everybody's memory should go when they're older. So if you ask somebody, how's this person's memory? Oh, they're fine. But what I do ask about are functions. So when did this person start needing you to book their doctor's appointment when they didn't need to 10 years ago? Or why can't they book their flights anymore? So on, right? And being home alone is not equivalent to being independent. I see that all the time. Patient home independent. Well, that's not true. They're probably either hanging on a thread or they need lots of help or they are getting help. So home alone isn't independent. Okay. As far as the physical examination in acute brain failure, gosh, you can do really a whole lot. But I often say let the history guide you and keep it sort of broad. So investigations, again, there are many. But what I'd like to mention is if the history is unclear, give the patient a little bit of benefit of the doubt, and you may need to do a broader workup. Patients with lower reserves or patients who are generally frail present atypically, so you may need to do a little extra. It's kind of like that talk we had on heart failure. They don't often present with florid edema. Half the time you sort of depend on a BNP that's like 10,000 and a few symptoms of respiratory distress or whatnot, right? Or respiratory symptoms. So you might need to add that. Right. And LPs and so on are not the common first step. So let the reserves guide you. If the patient has good reserves to begin with, then you may need to do a bit more. For some things, if the patient's unsettled or agitated, you may require a bit of anxiolytic or sedation to avoid motion artifact and imaging. So if you're sending somebody for an MRI and they're bucking with you, they're going to do the same thing. And so it's going to be bad for everybody if they go down. So we don't like giving benzos and sedating the heck out of everybody, but you may need to just to get a proper diagnosis. And then the indications for imaging, there are no clear rules. Again, keep a low threshold. If someone's got severe dementia, I will likely believe that this UTI is throwing them off a bit, so I may not scan them. Okay. But if they have focal neurological deficits, a history of head trauma, maybe they're anticoagulated, they have fever, you may think of encephalitis, decreased LOC with no identified etiology. Those are reasonable indications. And then the management strategies for someone in acute brain failure. Remember, the DSM-5 says there's often a stressor. So if you've identified it, you treat it. Sometimes you may need to treat empirically and then narrow, if it's like an infection, for example. And once you've treated it, and once delirium started, and you've treated and you've kind of dealt with the main issue, it rides its course. So you have to give it a little bit of time, some people more than others. And you may need to apply pharmacological strategies for those who are agitated, aggressive, maybe harm themselves or others. And of course, there's also non-pharmacological strategies as well. There are favorable outcomes when you use both. Okay, so there's a few non-pharmacological things as well to help in the process, right. Reducing bad stimulation, so on and so forth. There's all sorts of those things. Okay. Right. So pharmacological strategies we use if the patient's distressed, if they're harmed to self or others. And like I said, if you sort of need a calming agent for an MRI or LP. And the options are you start with the lowest effective dose. So for antipsychotics, you have Haldol, loxapine, patients refusing oral medications. There's risperidone and quetiapine, preferred in patients with Parkinson's disease or Parkinsonism. They all have their strengths. Some are a little more sedating, some have a little more risk of EPS. So be mindful of those things. And then you want to taper off or taper down the dose ASAP. So as soon as things are getting better, don't leave it on, start tapering it off and be mindful of their side effects. Benzodiazepines are preferred in patients with catatonia, of course, in patients who are coming in with DT, etc., or alcohol withdrawal. Right, and then there's syndrome-specific things you can use, or like neuroleptic malignant syndrome and serotonin syndrome. Those are your pharmacological strategies. What about rehabilitation during acute brain failure? So during acute brain failure, when we try to get our physiotherapists and them to see patients, we don't though, but when I first started, these are the kind of looks I was getting, right? So if someone's in acute fluid brain failure, and the definition is they're non-engaged, non-attentive, they could be either hypo or very hyper, they're probably not going to mobilize with you, right? So I say good luck. But as soon as they're improving, then it's a good time to consider. So, but the reason why I said is sometimes the rehab team sizes up. They may be spending 20 minutes getting a good sense of the patient, only to get there to find out that, oof, this is not good. Those 20, 30 minutes could have gone elsewhere, right? Okay, so what about resolution? So that depends on the patient's baseline reserves or intrinsic capacity and the severity of stressors. And depending on those things, they may not return to their pre-admission baseline, right? So somebody with good reserves, but they've gone through an anoxic brain injury that's lasted for a while, that's a massive stressor. They may not return. Somebody with severe dementia and a UTI, a simple UTI, may be enough not to get them back to their baseline. And so, so the study showed that the greater the pre-hospitalization cognitive impairment, the greater the cognitive decline after. So if you've had maybe just MCI, you'll probably get into the dementia range of things. If you've just had mild dementia, you may be now into the moderate range of things. And how do you determine a new baseline? Well, once the stressors have been managed, you're sure you've got everything, and the patient's making sort of marginal gains or is plateaued, and there's nothing else there's left to do, then they're likely getting to their new baseline. And so you can make a decision based on that for disposition planning or whatnot. Okay, cases. So there's a 77-year-old retired accountant brought into the emergency department 2 weeks ago for a 1-month history of new intermittent bouts of hallucinations, so psychosis, and dysfunction to higher order functioning. Right? That's kind of redundant. Higher order dysfunction, so has a hard time booking doctor's appointments now and so on. Went to the emerge, didn't look so bad, sent home for outpatient follow-up. Now brought back in today, symptoms have gotten worse, alert but not meaningfully engaging, sort of looks right through you when you talk to him, says random things over the past 24 hours. But prior to 1 month ago, I guess she still did her own finances, taxes. She did slow down a little bit, but she still was doing a bit of gardening and so on. And she's got a 40-pack history of smoking and has some unintentional weight loss, but it's been attributed to just getting older. So is she presenting with acute brain failure? Yes, 24-hour change, right? She's not engaging, 24-hour change, disorganized, saying random things. But then what about the 1-month history? So this is a picture of a rapidly progressive dementia that's culminating into acute brain failure. And so let's look at the stressors. Drugs, no. She's got some blood work with no leukocytosis, but a CRP that's 20. A urine that maybe pyuria, hard to say, maybe some trace leukes. Otherwise, everything's within normal limits. But you're thinking rapidly progressive dementia. So, is this encephalitis? Is this metastasis? Is this CJD? The CT head, though, was nil acute. What are the reserves? So the reserves are, so she's got no issues a month ago. So she's, stage 1. So good reserves cognitively. She does have COPD. So at an organ level, there are concerns. And overall, she is well-to-do or maybe just vulnerable to frailty because she has slowed down. So you'd say she's got high cognitive reserves. I'm going to think she might need major stressors to decompensate her, right? So what do we do? So this is a slam dunk, a little bit of pyuria, maybe this is UTI, empiric ceftriaxone, and admit, follow up on cultures, slam dunk. These are falling short this morning. Okay, do we just go straight to consulting psychiatry? This is schizophrenia, right? Or like we said, good cognitive reserves. UTI maybe, but I would dig a little deeper. Maybe we're looking at more colonization and infection with that sort of query-pyuria. But we would proceed to a full sort of rapidly progressive dementia / delirium workup in this person. So you wouldn't want to hesitate and wait, So whatever you need to do, MRI, LP, maybe a neuro-GIM consult if you're not GIM, right? And don't forget to give a little anxiolytic if they're kind of agitated. It may affect the PET scan, but not maybe as much the MRI. And we'll let you do the LP a little bit easier. Okay, so in this patient, what do we see? We see a bit of high intensity sort of in the limbic areas in the temporal lobes with the MRI. And this area is responsible for behavior, learning, memory, emotions. So that's why the patient's a bit more agitated. And when we start looking at that, we look at with the smoking history, look at the X-ray, and maybe there's some, spiculated mass here. And sure enough, there's a malignancy. So this is, sort of paraneoplastic encephalitis. This is just another sort of coronal imaging to show something, similar. So that's, in a nutshell, delirium and acute brain failure. We briefly touched upon rapidly progressive dementia. So let's continue on that path. There's no hard definition for it. It's less frequently occurring than the typical dementias. And they can occur, 1 to 2 years, like something like an atypical CJD. But typically, everything in the literature and clinically says it happens within weeks to months. So that's what I use. Okay. So the general approach is you want to determine the cause to see if it's modifiable so you can manage it and treat it right away. But even if there's no modifiable treatment, such as like CJD, giving clarity is therapy. Giving people something they can put their finger on for diagnosis helps. And it also changes the way they, for family members and others, the way they interact with the patients and so on. But clarity in itself, clarity is therapy. And then you can help with managing distressing behaviors. So the common causes, the classic, right? Prion disease, CJD, when we think of rapidly progressive dementia. But anything can cause it. We get surprised all the time, right? Things that should take a year, sometimes they react. An autoimmune, also you get autoimmune, or vasculitic related encephalitis, or, and then some of the common, neurodegenerative diseases that usually, I guess, take years can sometimes present in a rapidly progressive fashion. And we've seen some of that, typically with things like Lewy body or frontotemporal. This is like a little pearl. What I would say about rapidly progressive dementia is don't jump to the diagnosis in people that are already quite frail. So, I use moderately frail as, so it's somebody needing help with BADLs. Because often systemic frailty is often associated with cognitive frailty. In medicine, we learn things in a subspecialized manner, but the body is far more integrated than how we decide to manage it, right? So there's a bigger connection. So often there's no surprise if there's physical frailty, there's also cognitive decline as well. So instead of just running and jumping to an MRI and LP, ask questions around dementia, cognition, using the tools that we just talked about. And don't move the goalposts for aging, and don't conflate physical limitations for cognition. So if somebody's needing help with BADLs, I can imagine that they need help with getting into the bathtub and stuff, but why can't they book their doctor's appointments? Why didn't they help with medications? Don't conflate those things. It's likely dementia. This is just really, I'm kind of beating on the concept that if you are frail, you have a higher association with dementia. I mean, there's more articles in that. That's supposed to be dramatic, but. All right, so rapidly progressed dementia. It's helpful to establish an accurate baseline, right? We talked about not moving goalposts for aging, because you'll be doing MRs and LPs on everybody. Once you start realizing this is likely just BPSD and not something very concerning, right? I mean, it's all concerning, but BPSD you don't necessarily need to do too many investigations for. And there's one barrier, there's several barriers in trying to obtain a good history for reserves. It's a touchy subject. It's so much easier talking about cancer and diabetes. And I mean, Laurie's here. It is a bit easier talking about diabetes than it is dementia. It's very sensitive, even for geriatricians. I don't know, there's a stigma. It's like the old, it's like how it used to be for depression and so on. And the solution, I joke about this stuff. It's kind of like, it's like when I was telling my wife before I got married, I'm not sure, what she told me was get over it, right? So that was profound for me. So here, I'm sharing that with you. All right. Right, this is just the tool you can use to determine reserves, where somebody is, right? So the global deterioration scale, what stage they're at. Okay, so the workup generally is like a DIMS type workup, the Delirium type workup, and usually you're likely getting an MRI and LP at the very least. Like I said, you might require an anxiolytic or a neuroconsult. You may consider broadening your workup, even including an autoimmune workup, toxic metabolites, malignancies. So if something's not obvious, the radiologists don't like it, but pan scan or what have you. And EEG. And then sometimes you might need a white blood cell scan. Interestingly, we find some interesting things with these ones. Again, frail patients don't present typically, so it's interesting what you find with the white blood cell scan. We trend CRPs in this case because sometimes you don't know if it's an infection or autoimmune. And so if you are giving broad antimicrobials because maybe you think there might be an infection, but their CRP is climbing, it gives you at least some confidence to say, okay, we need to stop going this path. And maybe we'll try like a steroid or something for something more autoimmune related. And so we've kind of found success in that sort of an approach. I'm really simplifying it, but what I'm saying is you might need to use whatever tools you have available, trending CRPs, really going far into one strategy, knowing that you did the best you could, and then you can confidently change gears. And then biomaterial. So if someone's got obvious lymph nodes that you can biopsy, or even muscle biopsies, we've got an interesting case of polymyositis and so on. You can kind of get those things, and it'll give you clues or a diagnosis at least. And the last resort, which I've never actually seen, are things like brain or leptomeningeal biopsies. So different regions use a different approach based on what's endemic to them in their region for giving them rapidly progressive dementia. So some people like TB is huge or something like that. But for our own region, it depends on what we see commonly. Okay, I've kind of talked on all this. Right, so case 2, 69-year-old male who's got FAST2, so pretty good reserves, and is mildly frail with a history of heart failure, CKD, post-op day 6 for an open colectomy for diverticulitis, complaining of abdominal pain, not as engaging with nursing, and in bed all day. And they had a bunch of blood work and whatnot done. These are the medications. He's on morphine and fluids. And so good reserves at baseline. So I'm thinking, again, is this just, it has to be more than just a simple post-op delirium in somebody who's 69. Let's do a little more. So we often see this kind of stuff. So this is what the patient's vitals look like. Heart rate, blood pressure, 76% on 4 liters, and the rest rate's 10. So what findings concern you? I mean, if you think it's A, everything's good, you're probably in critical care. So that's fine. Okay, but I would say maybe B, C, and D. It's a few of these things are concerning. And if I told you the patient's sort of picking at things in the air, incoherent ramblings, not answering to any questions, is this acute brain failure? Yeah, it happened within 24 hours, not engaging. So that's true delirium. And yeah, pinpoint pupils, kind of a little twitchy. And so, it could be a number of things on your differential. Always keep it broad, so you're exercising your brain. But it's likely opioid toxicity. So we give naloxone, and the patient's now more alert, but a bit drowsy, but a bit more engaging, a bit more coherent. And when he is coherent, just saying, "Oh, my stomach hurts." And you see a bit of hematoma, it's a little bit red. You touch it, he's like, "Ow," but you're not sure he's delirious. How real is all this stuff anyway? Still a little hypoxic. So next step, job complete, walk away, time heals all wounds. Or, we need to follow up on investigations and re-examine the abdomen. So the BNP is at 10,000, a little bit of AKI. Yeah, and the patient's lost a little bit of blood. So, so really, this patient's also had superimposed acute decompensated heart failure, emerging type 1 cardiorenal, and so, saline lock IV, whatever, give them some Lasix, et cetera, and the respiratory status improves and the GFR improves. But we're still not done because the labs come and the CRP is now gone 100 to 200. And often the surgeons say, well, the CRP is supposed to be high after surgery. Yeah, but it shouldn't be like going high. It shouldn't be going 100, 200, 300. And you called us, by the way, so something's definitely not right, So, okay. So we got to dig deep, right? So sometimes it's like an insidious abscess, or in our case, this patient actually had an infective abdominal wall hematoma. I thought it was so painful. And so it was growing MSSA in it. We removed it, gave some empiric antibiotics, narrowed it down, got the surgeons to go back, wash it out, et cetera, et cetera. And the patient got better and actually started partaking in activities and rehabilitating. So the key here again is not all individuals or older people, whatnot, are the same. If you have good reserves, it takes a much bigger stressor to decompensate you. So look for those things. Okay, another one, 55-year-old individual with hypertension, AFib, and so on, but 2-year decline in ability to work as an IT specialist, was previously managing finances, but now needs blister packing and reminders, and since 6 months ago, requiring queuing for bathing and dressing. And as per wife, he's kind of becoming more agitated, anxious, confused, especially over the past year. And he's also making up stories, sometimes seeing things that are not there. In the last 2 months, less redirectable, and has been brought up to ER a few times, but the DIMS workup and all that stuff, CT has been negative. On the good days, looks forward to spending time with children, but now brought back this time to the ER because at 5 a.m. he was looking for something and yelling in the backyard. And he was swinging at the EMS, accusing them of stuff. So, vitals all within reasonable limits. He's got a reactive affect. He's telling his wife they need to get out of here. So he's a bit paranoid. Is unable to count down from 20 and so on and so forth. And he tells you he needs to get out because, he's a little agitated. He says people are going to get me and whatnot. So this is patient. Is he coming in with acute brain failure? Is this guy schizophrenic? Does he have bipolar? Is this BPSD? Is this rapidly progressive dementia? So he's CAM negative, and this is more chronic. This is years, 6 months, a few months, and the work has been negative. It doesn't meet the criteria for schizophrenia or bipolar. And I think in medicine, sometimes we should sometimes try to brush our, just brush the, what you want to call it. We should clear the cobwebs of just some of these criteria. We will re-familiarize ourselves with sort of these things. But remember, people with the older age, the odds of you having a new onset primary psych issue, the odds are very low, very, very low anyway. But if somebody has pre-existing primary psych issues, just know what a decompensated state looks like. I learned that the hard way. I was calling everyone sort of manic, and the psychiatrist said, "You can't say that." I was like, "Yeah, you're right." So anyway, I've been in that. This is what I'm saying. I've learned from that myself. Okay. So is this BPSD? Yes, this is BPSD. It's not rapidly progressive dementia because it's happening because it's not really in weeks to months. It's been happening for way more months and a couple of years. So this is BPSD. So you don't need to do much for this person. You can maybe use a low-dose antipsychotic with maybe a bit of trazodone, get a baseline ECG for QT, and then consult the right people. So whether it's geriatric medicine or psychiatry or geriatric psychiatry. And so let's talk a little bit about primary psychiatric disorders. A full discussion is beyond the scope of this talk, but be a little familiar with how to diagnose it or when to suspect it, or Google it, re-familiar yourself. familiarize yourself with it. And yes, like we said, the odds of having late age onset disorders are very low. So think about BPSD first before you think about schizophrenia. This is what the criteria look like. If you stick to them, it'll be very clear that the patient likely doesn't have it, or maybe has it. Now, if somebody has a primary psychiatric disorder, the odds of them having or developing dementia is high. So this patient was 55. So what do you want to start thinking about for patients less than sort of 60 if it's not rapidly progressive dementia? So alcohol-associated dementia, especially if it's long-standing, they commonly sort of present in their mid-60s. Frontotemporal usually happens around this age. Parkinsonism, typically Lewy body or corticobasal degeneration. But really anything that's going to damage your brain cells irreversibly, which is pretty much everything, but traumatic brain injury, hypoxic and oxic brain injury. We had an interesting case of somebody with the antiphospholipid antibody syndrome. For years was getting mini strokes and no one really thought much about it. Then eventually got depressed because when you can't do stuff anymore, you get depressed. So people started focusing on depression until they came to us with sort of hypoxia and delirium, and you try to find a unifying factor and showing us got clot in his heart. Then we start working it up back and saying, why is he hypercoagulable? So this gentleman had antiphospholipid antibody syndrome for years, and everyone just didn't think he may have had dementia because he's 50 something, okay. And if there are no hallmark features of the stuff above, you can always put the blame on Alzheimer's. We do. I'm just kidding. But there will be biomarkers coming in soon to be able to help us with that, okay? So there we go. So we've talked about sort of acute brain failure, rapidly progressive dementia. We've talked about a little bit about primary psychiatric disorders. The biggest thing that's going to be coming our way, or is it already here, to be honest, and it's going to be potentially getting worse, is this concept here, BPSD. BPSD, behavioral and psychological symptoms of dementia. And it's an emerging crisis of just all dementia. And it's estimated that up to 80 to 90% of patients with dementia will be affected or will get BPSD over the course of their illness. So it's not well diagnosed, it's not really well managed. There's reluctance to use medication, and it's associated with bad things, like bad. Okay, so it's the little bit here that the guidelines suggest, that's the new behavioral and personality changes, that little bit here. And so any cause of dementia can lead to BPSD. And most times it occurs towards the latter or the later stages of dementia, with the exceptions of things like Lewy body and frontotemporal, which tend to sometimes happen early or even precede the onset of dementia. But those are rare. For the majority of the part, when you already have BPSD, you've probably already been in the later stages. And once you get BPSD, it's a marker of a more steeper decline. So BPSD is an umbrella term. Anything gets impacted, any behavior, so it could be depression, apathy, which looks like depression, but not really, anxiety, mood disturbances, but psychosis and agitation is the kind of stuff that really brings patients to the hospital. And so, like we said, it does happen sort of in the later stages of dementia for most dementias. So sort of like the stage 6, depending on which tool you're using, it's sort of right here. So precipitating factors, a lot of this is intrinsically driven. I mean, the brain's responsible for function, filtering, perceptions of reality. So if you're starting to unravel, it's intrinsic. So a lot of people say, well, you need to talk to the patients, focus on non-pharmacological stuff. But you know what I say, not just me, but other, disruptions in sort of cardiac circuitry, you can't just redirect a VT. You have to kind of use other things, right? Okay, so, but there are also, of course, extrinsic factors, anything that sort of precipitates any stressor, really, even minor stressors. So think constipation. A lot of these patients with dementia can't tell you they're constipated or you're not sure, but just do a flat plate if you're not sure and clear them out. So the thing about BPSD, unlike delirium, though, is like unless there's evidence of something or an alternative cause, often imaging and other labs are not necessary with patients with gradually worsening BPSD. And it's not as emergent as delirium, but the patient could become a significant harm to self or others. So that's when it becomes a problem. So just more that it's not just a thing in dementia. I mean, it's a real physiologic, pathophysiologic sort of process. So you can't always talk your way out of BPSD. Again, the same thing, there's many factors. There's intrinsic, extrinsic, all these sort of things we need to take into account. So what do we do? Well, so how do you manage BPSD in an era of boxed warnings? So in a nutshell, you do both. Pharmacological and non-pharmacological strategies have the best outcomes. Okay. But realistically, in the acute care setting, I tend to see, I guess we all sort of, to some extent, tend to see sort of two big scenarios. You see this crescendo BPSD that's really peaked. It's kind of not been well managed for a month, 2 months, and it's really peaked. And your patient's unredirectable. So it's distressing psychosis, agitation, patient's uncooperative. And so in those cases, you can use things like loxapine or Haldol. And there's a big, again, stigma using it. But what I say is put aside the dogma, put yourself in the nurse's shoes. If you're not okay with going to the patient's room at striking distance, right, don't put the nurse in there with the same risk. So not all of us like using all meds all the time, right? Especially kind of antipsychotics, but there is a role for them. And it's probably better for the patient and whoever's going to be looking after them. They may require some benzos acutely. MERS does a wonderful job doing that. Okay, so scenario 2. If a patient's only starting to become difficult, so there are also these cases where they're starting to become a little difficult, a little bit of caregiver strain. The patient's not causing much of a ruckus. They're mildly agitated but cooperative. You've kind of looked at small insidious things like constipation, which tends to get missed because they'll get a blood work, a CBC anyway through emerge and all that other stuff. You can potentially send these patients home. So often we will say, no, don't need to come in. In fact, coming to the hospital will make things even worse. It's noisy. There's weirdos in the hospital. We have also, that's terrible. Okay, look, but seriously, it's not the most conducive environment for patients with BPSD. That's low grade, right? So you better to send them home. And right, and then often other scenarios are like post-resolution of delirium. So delirium's gone, and now you're seeing BPSD. Okay, right. So what do you do in this situation? So if you're going to admit them, establish a pattern. So try to get nurses to do behavioral charting or try to be mindful of it. So are they sundowning? When's the onset time? Does it make sense to give risperidone at QHS when they're onsetting at like supper time? You want to be, maybe an hour ahead of giving that medication so they don't take off. Get a baseline ECG just so you've noted their QTC. But even if it's a little high, their quality of life is hinging on their behaviors. So don't not give something because of a prolonged QT. But if you do, look, if you want to narrow it, look for things. Look at their magnesium level. You want to tighten up that gap, sure, right? If you want to remove other unnecessary QT prolonging agents, fine. That's very noble, and that's the thing to do. If you can determine the baseline rigidity to see if they develop neuroleptic malignant syndrome down the road, that's fine. But often I find these guys have like peritonia. They don't cooperate. So just try anyway. Some do something. Better. Okay, what about medications similar to the ones we've seen? So risperidone is Health Canada approved. But for patients with Parkinsonism, you want to use quetiapine. It kind of has the best evidence for this demographic. It is a little more sedating. So again, be mindful of those things. And for those patients who don't take PO or a little agitated, we tend to sometimes use loxapine. It's a bit sedating, and it's kind of, it works. There is a really cool sort of algorithm, a sequential treatment for algorithm for patients who are not redirectable, agitated, but agreeable to taking PO meds. It's by Davis et al. I encourage you to take a look at it. You can Google it. It's available. It used to talk about the main pathway, risperidone, unless of course have Parkinsonism, and then sort of you can add trazodone to the mix and so on. And if someone's already got sort of a BPSD that's taking off, I find that SSRIs and cholinesterase don't cut it. You're sort of kind of a little bit late to the game. Right. This is one of the authors here is Vincent Wu. He's one of the geriatric psychiatrists. So we often try to get to Wu Wu him to get to see our patients. And he's a good guy. Okay, so it's very cool, this thing right here. Yeah. What about non-pharmacological strategies? What you're trying to do is calm patients, give them a purposeful existence. That's half the battle with these people. They don't know what's going on with them, but all they know is that they're not doing something meaningful. So, sensory enhancements, their social contacts like pet therapy and whatnot, but these are the most effective when the patients are redirectable and not likely to harm self or others. So you can do pet therapy to somebody who's agitated and violent, the pet's gonna need therapy. So, right, so in hospital, like you wanna try to give them an existence. So there's recreational therapy. I don't know if you guys have rec therapists here. I think that they're awesome, right? I mean, they're very good at they're just good, period, right? And then other similar strategies with those with sort of evolving and resolving acute brain failure. It's hard to deploy ideal non-pharmacological strategies in a busy acute care setting. And so as they're getting better, more the reason to send them to a place that's non-acute. So more the reason to advocate for a discharge, early discharge. So BPSD, so what you might need to do practically speaking as well is initially ramp up on the pharmacological strategies in a busy acute care setting at the top. That's, often seems to be short-staffed. And while managing the organic or exacerbating factors, and while the patient's adjusting to the new environment, and while the allied health staff and others are applying non-pharmacological strategies. And then the goal is to essentially aim to titrate off the pharmacological strategies or use the lowest, most effective dose. And then you may not be able to titrate all of it in the hospital, but maybe later with the follow-up, when they're in a much better, quieter, calmer setting, you can achieve that. And so, yeah, this deprescribing whatever you've started them on may not be necessarily tenable in the hospital. Now, what I'll say is this: if you're the person who's reducing the dose, you should get follow-up. Either you follow them up or get somebody to follow them up right away. Because what you don't want to do is set it and forget it, right? Remember this guy? Did I just age myself? Yeah. Because if there's, people often do, and then they just say, well, yeah, I deprescribed. Then they show up to merge, and if I'm on the other end of it, how am I going to feel about the thing? Yeah, it's not about me, but yeah, just make sure you follow up then. Okay. It's kind of like taking off Lasix in someone heart failure or going down. Now, there's a chance you may make decompensated heart failure again, so it's the same sort of analogy. So follow up closely. And what about rehabilitation during peak agitation psychosis? Again, we've sort of seen this slide, but there is evidence that management of BPSD, so better management, can actually lead to better functional recovery. So these things should go in tandem. I know it seems intuitive, but sometimes you need evidence these days too. Okay, right. BPSD in the community is undermanaged, and we don't know why, but it could be because everything's labeled delirium, right? So confusion, delirium, therefore hospital. There's probably unclear knowledge or approach to management on the topic. It is a touchy topic, like we said, and there's not nearly enough geriatricians or geriatric psychiatrists to manage it. So sort of it's my kind of secret hope, or not so secret now, that at least in the initial phases, it can be diagnosed and managed by all of us, kind of like we do for anemia or heart failure, right? So because we don't go right to Andrew Fagarsanu for, anemia NYD. Although he's such a nice guy, I probably see it anyway. But Arabesque, Arabesque, though, I'm just kidding. Arabesque is awesome. Okay, so, right. But, I get the point, right? So, okay, so, and then unlike delirium, BPSD can be managed in the community. And so it's the ideal environment before things get into a peak sort of setting. And so there's a role of telehealth, which was in this study found to be acceptable and feasible for patients and caregivers, decreased intensity and frequency, and improved caregiver well-being. And there's so many different studies now that are showing the same thing. There's different algorithms and so on. But the point here is that it's doable. It can be managed, doesn't necessarily need to come in hospital. And if they are, you can and should discharge these patients early. Okay, so in a nutshell,
Not a nutshell.
yeah, that's a nutshell. Yeah, there's a lot. Yeah, that's okay. Well, yeah, fair enough. Okay, well, so there's this concept of chronologic age versus intrinsic capacity. I would urge you to start thinking, at least if you want to start tailoring care, as the patients in front of you having a certain degree of intrinsic capacity or reserves. And the older age or whatever is not a homogeneous demographic, so we can't apply dogmatic principles to them. Confusion is a confusing term. It'd be nice to start getting away from that and start applying things like probable or possible delirium or BPSD or whatnot. And let's try to distinguish these entities. And let's try to move away from labeling everything delirium. And appreciating that good reserves take a lot more to discombobulate. Low reserves take a little less. Rapidly progressive dementia typically takes weeks to months. BPSD often emerges gradually. Not all of them need to come in, but if they do, you need to be a bit assertive in your management strategies. Let's be familiar with our primary psychiatric disorders. at least to appreciate that the late age onset's not common. Yeah, but when they do exist in somebody, the chances of dementia are higher. And there we go. Oh yeah, just I think it is some of my colleagues have reviewed my slides. Make sure that I'm not going off too far. And yeah, any questions? Fräulein?
I'll bring you the little green cube, Fräulein.
Yeah. Yeah. So thanks. That was very informative. As someone who lives with emerge and GIM wards, it's really hard. It's easier said than done. To say delirium versus BPSD, which is relatively a new concept. But just thinking about it, practically speaking, I had a lady who just stripped naked while in Southview recently. And after being admitted under accent, delirium being cleared and realizing it was all dementia, we still couldn't send her home because she had to go to rehab. So I'm not sure that you could say that because it's BPSD, you would send them home. Because most of the time you still need to clear them and the family is hesitant to take them home because it's very distressing or distressing to them.
Yes, you're right. Some is, yeah. So, but we see different shades of it. There's like 50 shades or more of BPSD. And there are those that if they've gone on for a while. So again, there's this very cool, so I can't go back to my slides, unfortunately, can I? There's this, you're touching on precisely what, very good point. Let me go back to this. Yeah, this is gonna take a little forever. Do you remember that? Yeah, this one here. So the associated, so you have the intrinsic issues, caregiver. So the severity of, right, like you said, the BPSD itself is a problem, how much caregiver support they can get, and so on. And for some, you're right. And that's why we have Villa Caritas, fortunately, or even Jerry Psych that are available. But there are others where if you identify them early, or they do come early and we see them, and maybe MERS doesn't call you as much, but when this thing is going to get more and more, I think we're all going to be sort of hands on deck with it. There will be some where you can. And for those, we send them home. We often get Villa, outpatient Villa. So Villa sometimes goes to your house to see them. There's home living care, elderly that can follow, or and so on. So with supports like that, we can for some. Yeah, but you're right. There are those you made a good decision on that. Yeah.
So taking that on forward, I think Brian's made a very good point. Are there questions that you might ask people in the primary care setting to try and make a better diagnosis of what might be an acute delirium versus a BPSD and might not need an emergency response? Because I think we're falling into that trap of the specialist saying, oh, well, you can do it in primary care, when clearly both confidence and competence are lacking. They don't see enough. So what questions would you advise to try and increase that diagnostic certainty and say, okay, I can let this thing go and watch for a little bit more versus get them into internal medicine or geriatrics and get them sorted out?
Right. So there are a few questions. First is, well, this has been a gradual onset. So not moving goalposts. And how bad is it? You know, is the patient a little bit redirectable? Yeah, they're sort of listening to family, but it's sort of getting to the point where it's not happening as frequently. For those guys, you know, and the family still wants them home and right? So again, intensity, the amount of support they have, those are the biggest ones, right? And with that, often with a bit of medication, we have kept them out for months, years, et cetera, et cetera. So I think those are the two biggest questions.
Yeah, and the other thing, of course, there, Fräulein, we do have care of the elderly and geriatricians in the community who can help too.
So that would my follow-up question. How quickly, realistically, can you guys see them if you're hoping to discharge them?
Well, we can see people within the hour in the emergency department. Secondly, a referral through the transition coordinators to home care for the geriatricians is pretty quick assessment now and pretty readily available in 3 of the 4 quadrants.
Yeah,
thank you.
And when we sent somebody home from the emerge, we had Villa Caritas follow this patient. We had sent a requisition. They were there within a week and a half. But I'd send the patient with a little bit of risperidone, and that helped with all the, you know, if things were bubbling up too much. And I kept them at bay. They allowed home care, and Villa came within a week and a half.
Second thing, pet therapy when possible in the hospital.
Oh, yeah, no, I know.
But we've used dogs.
Oh, yeah,
And
dogs,
work.
I have seen dogs wandering about with, but they're fixed visits and they're never enough. I think Adriana's got a question.
Yeah.
Give him a dog or a doll.
I really enjoyed your talk. I learned a lot, and I'm so glad you talked about constipation as impossible. But actually, along those lines, I'm curious from a geriatric perspective, how would you manage it? Because I know how I would manage it in GI, but in the specific patient population, are there certain pitfalls, things to avoid, or preferred approaches?
How to manage constipation? Adrian, no, okay.
Much the same as you, actually.
Oh.
But the main problem we have in institutional settings is the staff restricting availability of, say, polyethylene glycol, where we're saying exactly the same as you, have the confidence to change the dose, you will not poison yourself. But we have to have an order. You know, an order to breathe in after you breathe out is really important. And that's often very limiting.
Yeah, and the other thing I would add is in patients who tend to get severely constipated, well, how do you, well, nowadays you can ask if you're not sure, you can send a flat plate and actually ask them, give me a severity score. So they have like these severity scores, right? Oh, if they call anything medium or moderate, just raise it up a little. It's usually more than that. I usually sometimes follow it up with another x-ray to make sure it's clear, because what happens is you might try to clear them out a little bit. So I usually say clear them the heck out, is what I tell family. You can't play footsies. If they're bunged up and you're just trying to do like maintenance pig, you're not sure if now they're getting overflow diarrhea or like you've over-cleared them. So you want to be sure, clear them the heck out, right? So whatever you need, right? Magnesium, whatever. Yeah, don't judge me, but you, and if you're not sure, I sometimes follow up with a flat plate again or ask the family doctor. Then you can be more certain that you clear them out. And then you make sure they're on a good maintenance regimen. Yeah. Yeah, I don't know, Adriana, is that okay? Okay, good, I get it, so that's great.
And the only thing he had cautioned about was, of course, the dustbin diagnosis of UTI on the basis of a positive urinalysis. My most recent, where I referred to in emergency department, confused little old man, 97, has a UTI, mucky urine, actually had bilateral pinpoint pupils and upgoing planters. It had a pontine stroke, and of course died 3 days later. So dustbin diagnosis.
Yeah.
Thank you. Thank you, Dr. Rajamani.
Thank you, Dr. White. Thank you, everyone. Thank you.